Hello and welcome to this ECG Interpretation lecture series. My name is Theo and I'm one of the doctors at the Princess Alexandra Hospital. I've been working with Dr. William Wang, one of our cardiologists, to create this resource for medical students and junior doctors. My main aim in this series is to help you feel confident in your ability to interpret the ECG and to go on to practice safely as a doctor. I also want ECGs to make sense to you. Rather than memorizing a list of rules, I want you to understand what you're seeing. If I can convey that to you, I'm sure you'll be able to practice more confidently and safely as you move through your medical training. So this is a 5-part series. This first lecture is on the basics, so how to understand the different parts of the ECG. And then the remaining 4 lectures are much shorter pathology-based lectures. So we start with myocardial ischemia, we move on to conduction disease like heart blocks, then tachyarrhythmias, and then we finish with some miscellaneous conditions that can be seen on the ECG. Okay, so this here is an example of a normal ECG, which I've included mostly just for your reference. What we'll actually be working through in this lecture series is this ECG, primarily because there are actually some abnormalities for me to point out as we go along. So whenever you're interpreting an ECG, it's always important that you have a system so that you avoid missing things that are subtle. Now, the system that I recommend is this one here, and that is that you start by looking at the 3 initial features, okay, and that's the rate, the rhythm, and the axis. I'd also mention you should comment on whether or not it's regular or not. I throw that in with rate. So after rate, rhythm, and axis, you move on to waves and intervals. And here they are here. But it's easier just to read them off the ECG rather than trying to memorize a list of things that you have to do. You just start with the P wave. What comes next? The PR interval. Then the QRS complex. Then the ST segment. Then the T wave. And then the QT interval. And you see by doing this, there's no need to memorize any lists. You just read it off the ECG. Now, if you have a system like this, it really is your get out of jail free card, because even if you have no idea what any of it means, as long as you can describe the abnormalities to a more senior doctor, they'll be able to help you out. Now, this lecture will go through these things one at a time, so let's get started. Now, when we're interpreting an ECG systematically, one of the first things we should probably mention is how to check if the ECG machine has been calibrated correctly. And the way we do that is by looking at these calibration spikes over here on the left. So, if the ECG machine is calibrated correctly, that means it's calibrated to a printing speed of 25 millimeters per second for the paper, and each 1 millivolt of electrical potential will cause a 10 millimeter deflection on the ECG itself. Now, you don't actually have to remember those numbers. The point is, if the calibration spike is the right size, then it's calibrated correctly to those numbers. So the correct size for a calibration spike is 2 large squares tall, as you can see here, and 1 large square across. So if we go back to our previous slide, we can see calibration spike, yep, 2 large squares tall and 1 large square across. Probably a bit more important is that if it is calibrated correctly, that means you can rely on your timings. So 1 large square is 200 milliseconds, and 1 small square is 400 milliseconds. And that's going to be important later on when you're measuring your waves and intervals and the durations of different parts of the ECG. Okay, so 3 initial features: rate, rhythm, axis. Okay, what's the heart rate? Well, there are a couple of different ways of calculating the heart rate when looking at the ECG. The most common is 300 divided by the number of large squares between QRS complexes, or in what's technically called the RR interval, okay, the interval between the R waves. So if you have only 1 large square, then 300 over 1, that's 300. 2 large squares, the rate's 150, so on. Alternatively, and I think it's much simpler, just count the number of QRS complexes in the rhythm strip along the bottom. Now, the whole ECG is 10 seconds long, so if you multiply it by 6, that gives you 1 minute. Now, I'd say this is much simpler, mostly because I think division is hard, but it really is important to know both ways. Okay, so let's answer what is the rate. So, if we count the number of QRS complexes in the rhythm strip, that's 9, multiply by 6, 9 times 6 is 54, and there you go, the rate's 54. But I did mention it's important to know both ways. Now in this ECG here, I'd say it's still definitely easier to count the QRS complexes along the rhythm strip. And that gives you 17. 6 times 17 is 102. Okay, rate's 102. However, as you can see, this ECG is quite irregular. If you tried to use the other method, you'd get different answers depending on which part of the ECG you measured. So if you measured here, well then you'd get 4 large squares. 300 divided by 4 is 75. If you measured somewhere else like this, you get 2 large squares. Rate's 150. If you know both of these methods, then you can report the average rate as 102, but you can also give a range that over this 10-second strip we varied from a rate of 75 up to 150 per minute. Okay, so the next question to answer is, what is the rhythm? Now, the rhythm can be quite tricky to identify, especially on very tachycardic ECGs. Well, in this case, it shouldn't be an issue. But before we get into the details, it's important that you understand what we even mean by rhythm. Okay, now what we mean by rhythm is where the action potential started. Okay, so in sinus rhythm, that means the action potential started at the sinus node. Okay, so looking at this diagram here, atria on top, ventricles on the bottom, sinus node, AV node, bundle of His, bundle branches. Now, if this is sinus rhythm, it means the action potential started here, it then spreads out and activates the entire heart, and then the whole heart beats in rhythm with the sinus node, okay, because that's where the action potential started. Now, the action potential could have started somewhere else, such as the AV node, okay, and in that case, the action potential would spread upwards and downwards, and eventually the whole heart would be activated from the AV node, and it would be in rhythm with the AV node, and so we would call that an AV nodal rhythm. While we're on this point, because the AV node is at the junction between the atria and the ventricles, it's often described as a junctional rhythm. It's the same thing. AV nodal rhythm, junctional rhythm, it's the same thing. Now, if someone says there's an atrial rhythm, it means some part of the atria that's not the sinus node and not the AV node is firing first, and that's where the action potential is starting from. Okay, and that's called an atrial rhythm. If the rhythm were to start somewhere in the ventricles, then we would call it a ventricular rhythm. Okay, so what is a normal rhythm? I'm sure you all know this, it's sinus rhythm. But how do you know if the heart is in sinus rhythm? Now, most medical students seem to tell me some variant of every P wave needs to be followed by a QRS complex, or it has to be regular. Neither of those things actually have to be true for it to be sinus rhythm, okay? Now, we've already said sinus rhythm means the action potential is starting from the sinus node, okay? Now, if the action potential starts here, then it should spread down and to the left. Now, if you remember where your leads are placed, lead 2 is placed down and to the left. AVR is placed up here. So, if the action potential starts at the sinus node, it should spread down and to the left, directly towards lead 2. So lead 2 should be positive and upright. We're spreading directly away from AVR, so AVR will be inverted or negative. Okay, and that is the characteristic of a sinus P wave. Okay, now each P wave should also look the same, as long as you're looking at the same lead. If that should make sense, because every P wave is coming from the same spot, the electrical activity is going the same direction each time, we should always get the same shaped P wave within that lead. And to make that a little bit more clear, I've done this diagram, and we've got the sinus node here, AV node, and here's the P wave action potential. So as you can see from a normal sinus beat, the action potential starts here, travels down and to the left and towards lead 2. So lead 2 has a positive P wave, and it's heading directly away from lead AVR, and so AVR has a negative P wave. With that background knowledge, now you'll be able to tell me, is this sinus rhythm or not sinus rhythm? Okay, so we start by looking at lead 2. Are the P waves upright? Yes. Then we look at AVR. Are the P waves inverted? Yes, they are. Then we have to check that each P wave looks the same within one lead. The rhythm strip's the easiest place to check, so upright, 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 they're all about the same shape. Fantastic. This is a normal sinus rhythm. Okay, what's the rhythm on this ECG? Well, we start by looking at lead 2. Are the P waves upright? No, they're not. Okay, they go down and then they go up. Then we look at AVR. Are they inverted like they're meant to be? No, they're upright. So this is not sinus rhythm. I'll point out here that every P wave is followed by a QRS complex. It's perfectly regular, but it's still not sinus rhythm, okay? This is an atrial rhythm. The rhythm has started, or the action potential has started from somewhere other than the sinus node. What about this ECG? Now, same questions. Are the P waves upright in lead 2? Yes, so far so good. Are the P waves inverted in AVR? No, they're not. Now, this highlights the importance of checking that each P wave looks the same, because if you look across the rhythm strip, you'll see the first 4, they look about normal, but then something changes, and from then on, every P wave is inverted. So something changed here. What we've actually got in this ECG is sinus rhythm for the first 4 beats, something changing, and then going into an atrial rhythm from here on. And so this highlights the importance that you do need to check all the P waves in the rhythm strip and make sure they look the same. So the next thing to describe is the axis. Now, before we can describe the axis, it's probably worth understanding what we actually mean by axis. So the axis is the average direction of the electrical potential during depolarization of the ventricles. Okay, basically the average direction of the electrical activity as the ventricles activate. Now, I want to emphasize that this is the electrical activity, okay? It's not the physical position of the heart in the chest, alright? So, if someone suddenly develops a right axis deviation, it's not because the heart is rotated around to the right, okay? It's electrical activity that we're talking about. Now, we can describe an axis for just about any part of the ECG. In fact, what we were just talking about with the P wave in sinus rhythm, well, that was just the P wave axis. We were saying that the P wave axis is down and to the left, okay, in sinus rhythm. So you guys are actually already all over axis. Now we're just going to talk about the QRS axis. What's the normal range for the QRS axis? Well, it's much easier if we look at a diagram. So, starting with lead 1, which points straight out to the patient's left. Then we've got lead 2 down at 60 degrees. Another 60 degrees gives us lead 3. AVL is up at what we define as negative 30 degrees. AVR is also sort of a negative 30 degrees, but on this side, so like negative 150. And then AVF, F for foot, it's straight down. Now, what is the normal range? Well, it's all of this area here, from negative 30 to 90 degrees. Now, anything beyond negative 30, less than negative 30, is described as left axis deviation. Anything past 90 degrees here is right axis deviation. And anything up in this quadrant is your extreme axis, or your northwest axis. When you're interpreting the axis, you're going to have to look at the QRS complexes and decide whether they're positive or negative. Now, when a QRS complex is predominantly positive, okay, so the deflection is more upwards than it is downwards, okay, it's positive, well, that means we are depolarizing towards that lead. On the other hand, if it's predominantly negative, okay, it goes down more than it goes up, then we must be depolarizing away from that lead. You can get leads that are exactly equal, and that is described as an isoelectric lead. In that case, the depolarization is at 90 degrees to that lead. And then by comparing them all to this diagram, you can figure out the axis. One thing to mention is that when we're deciding whether the QRS complex is positive or negative, the baseline that we're comparing to is always the TP segment, okay? It's the part after the T wave and leading up to the next P wave, okay? The TP segment. And this is our baseline for anything on the ECG. When we're looking at the QRS complexes, when we're looking at ST segments, it's always compared to the TP segment. So how do you actually calculate the axis? Well, I'd recommend you start by drawing a grid, then looking at leads 1 and AVF, and then look at the relative heights of the QRS complexes in those leads, and that will tell you the axis. So putting that into practice, here we go. We start by looking at lead 1. Now the reason we've chosen these leads is lead 1 is nice and horizontal, straight out to the left. AVF is straight down, okay, at 90 degrees to lead 1, it gives us a grid. Now looking at lead 1, if lead 1 is positive, well that means the action potential, or the depolarization, is going towards lead 1. Okay, so the axis must lie somewhere in these two quadrants. Okay, it's not over here, so we're going to ignore those quadrants for the rest of this case. Then we're going to look at AVF. Now, if AVF is also positive, well, that means the axis must be heading towards AVF. Must be in one of these two quadrants. But we've already excluded that one, okay? So now we know that the axis must lie somewhere within this quadrant. So if we go back to our previous diagram, we know that everything in this quadrant is normal range, okay? So if you've got positive in one, positive in AVF, then you know the axis is somewhere in here, and you know it's a normal axis even if you don't know the exact number. Alright, let's try on an actual ECG. Alright, so what's the axis on this ECG here? Well, we start by assessing lead 1. Lead 1's positive, so again, we know that we're somewhere in one of these two quadrants. Alright, assess lead AVF. AVF is also positive. Alright, so now we know we're in one of these two quadrants. We've already excluded down here in the patient's bottom right, so that means we're left with an axis somewhere in here. Alright, going back to our diagram, that's all within the normal range, so this is a normal axis. Very good. Now, you can also see that lead 1 is slightly taller than AVF, and so the axis is probably not sort of right in the middle, okay? It's not right at 45 degrees. Lead 1 is taller, so it's probably a little closer to lead 1. So this is probably 35 or 30 degrees, something like that. Okay? And here's another one to practice, okay? So what's the axis? Start by drawing a grid. Alright, start by looking at lead 1. Lead 1's positive, okay, so we're on this side. What about AVF? Okay, AVF is negative in this case, so that means we're going away from AVF. Alright, so that means we must be somewhere up here. Now, we can compare their relative heights. AVF is bigger, okay? It's more negative. So the axis must be closer to this end than to this end. So we could draw in our arrow, and there we go. Now, if we look at our original diagram, we'll say, well, that's probably a left axis. But let's say you weren't so sure if it was left axis or if it was somewhere down in this little sliver of normal range. Okay, we know we're in this quadrant. The only way to figure out where we are in that quadrant is with the relative heights. And let's say it was a little bit indeterminate. Okay, you weren't really sure which side of the line that you're on. Alright, so you're not sure, is it a normal axis or is it a left axis deviation? Well, if it isn't obvious from the size of the lead 1 compared to the size of AVF, okay, I would argue in this case AVF is bigger than lead 1, so we know we're up here. We know this one's a left axis. But if it wasn't obvious, look at lead 2. Lead 2 is exactly 90 degrees to this line, okay? So if lead 2 were positive, well then you know you're on this side of the line, and that means you're within normal range. If lead 2 were negative, we must be going away from lead 2, we must be on this side of the line in left axis deviation territory. So going back to here, assess lead 2. Lead 2 is negative, so we're somewhere up here, left axis deviation. So we've done our three initial features, rate, rhythm, and axis, so now we'll move on to waves and intervals, starting with the P wave. So do the P waves look right in this ECG? Let's go through it. So as you know, the physiology of the P wave is atrial depolarization, and because the atria have much less muscle mass than the ventricles do, you would expect the P wave to have a much smaller voltage than the QRS complex. A normal P wave, as we've discussed for sinus rhythm, should be upright in lead 2, it should be inverted in AVR, and within the same lead they should all be the same shape. There are some P wave abnormalities you should look out for, so for example, a tall P wave in right atrial enlargement, and that should make sense to you. Big atrium, we get a big P wave, and we usually quote 2.5 millimeters as the cutoff for a large P wave. There's also some shapes, so for example, the bifid P wave in left atrial enlargement, so an example of that here. And again, that should make sense. As you know, we start depolarizing from the sinus node in the right atrium, we get through the right atrium, and then we hit the big left atrium, so we get this sort of second peak, and overall your P wave gets this bifid shape. And it's also worth noting whether each P wave is followed by a QRS complex, which of course it might not be if there are certain things like heart blocks going on. Putting all that together on our example ECG, the P waves here look normal, so none of them are more than 2.5 millimeters tall, each one's followed by a QRS complex, and they're all about the right shape. So moving on to the PR interval, is the PR interval normal in this ECG? Well, let's first make sure we're all on the same page about the PR interval. So the definition, the PR interval is defined as the duration from the onset of the P wave to the beginning of the QRS complex. It doesn't matter if the QRS complex starts with a Q wave or an R wave, it's just to the start of the QRS complex, whichever part comes first. Physiologically, it includes atrial depolarization and contraction. Okay, so although the atria activate during the P wave, they continue to contract throughout the whole PR interval. And I should mention that the AV node holds up the electrical signal here, delaying it from entering the ventricles too soon, so the atria have time to finish contracting first. So the normal range for the PR interval is 120 to 200 milliseconds, or 3 to 5 small squares. The abnormalities you should be aware of: if it's prolonged, well, you'll see that in heart block, so basically longer than 200 milliseconds or longer than one big square, or it can be too short, less than 3 small squares. And that might happen, for example, in pre-excitation syndromes, such as Wolff-Parkinson-White, and hopefully that makes sense to you. In Wolff-Parkinson-White, we have an accessory pathway that connects the atria to the ventricles, and it doesn't go through the AV node. So in that case, the electrical signal doesn't get held up, it moves straight on into the ventricles, they begin activating early, and the QRS therefore starts early, and so the PR interval is shorter in that case. So assessing this ECG here, is the PR interval normal? Alright, from the start of the P wave to the start of the QRS complex, it's about 4 small squares, 160 milliseconds, so this is a normal PR interval. Now to make this easier, when it's the middle of the night and you're on ward call trying to figure this out, just try to find a P wave that lands pretty close to pretty close to one of these heavier lines. And then if your QRS complex starts within the same big square, well then you know it's occurred within 5 small squares, you know it's not prolonged. What about this example here? Is the PR interval normal? Again, I've blown it up for you to make it easier. We found one that lands on the line, and as you can see, the QRS complex starts after, in the next big square. So this 5.5 small squares, this is a first degree heart block. This is a prolonged PR interval. After the PR interval, we have the QRS complex, so let's go through it. As you know, the QRS complex is the recording of ventricular depolarization. Okay, that's the physiology here. Things that you should look for include the width. Okay, is it narrow complex, which is normal, or is it wide complex? You should look at the height or the voltage. Okay, so a high voltage causes a tall QRS complex. And we should look at the shape. So the things that I'm going to mention with regards to shape will be Q waves, R wave progression, and bundle branch blocks. I'll save bundle branch blocks for a different lecture on conduction disease, but these all change the shape of the QRS complex, so when you're interpreting the ECG, this would be the time to look for them. In terms of the width, the normal duration of the QRS complex is less than 3 small squares, or less than 120 milliseconds. Any longer than that, and you start to call it a wide complex. Now, why is it so important to note whether the QRS complex is wide or narrow? Well, there's only really one way to get a narrow QRS complex, and that's for ventricular activation to happen via the normal conductive pathways. Okay, so you have to go through the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. If all of that happens, you get a narrow QRS complex. On the other hand, there's quite a few different ways to get a wide QRS complex. It could be a conduction issue, like a bundle branch block. It could be that the beat is ventricular in origin, okay? It didn't even start at the sinus node and travel down the conduction pathways. It started somewhere in the ventricles. Or it could be an accessory pathway, like in Wolff-Parkinson-White. That accessory pathway activates a random part of the ventricles, and because it's not following the usual conduction pathways, the signal spreads slowly and you get a wide QRS complex. The really important point here is that a wide QRS complex, meaning abnormal activation of the ventricles, because everything's happening out of sync here, everything after that QRS may also be unusual. So a wide QRS will often be followed by ST segment and T wave changes, and it's hard to interpret what they mean because they could be secondary to the QRS complex. Okay, so what I'm saying is if you see ST segment elevation after a wide QRS complex, is that because the patient's having a STEMI, or is the ST changes, are they just due to the QRS complex? So the reason it's so important to say whether the complex is wide or narrow is because if you have a narrow QRS complex, you know that every change you see afterwards in the ST segment and T wave, that's a primary change. Okay, it's not due to the QRS complex, it's due to some primary issue with the heart. Moving on to the significance of QRS height. Well, if, for example, there's left ventricular hypertrophy, you get a high voltage in a tall QRS complex. And we should also mention there's times where you'll get a low voltage QRS complex. So for example, with a pericardial effusion, all that fluid sitting around the heart, well, that gets in the way of your recording of the signal and you get a low voltage QRS. Okay, so it's important to comment on both the width and the height of the QRS complex. Next is the Q waves. So let's go looking for any abnormal Q waves. Again, definitions. If the first deflection of the QRS complex is downwards, then it is a Q wave. Okay. If the first deflection is upwards, then it's an R wave, and the deflection after that is an S wave. So in this picture down here, we have an R wave followed by an S wave. There's no Q wave in this QRS complex. All right. So for it to count as a Q wave, it has to go downwards, and it has to be the first part of the QRS complex. Now physiologically it's caused by the septum, okay? It usually depolarizes left to right, okay? And so that causes some small Q waves in the left-sided leads, okay? So lead 1, AVL, V5 and 6, perfectly normal to have some Q waves in those leads. When you see Q waves, you've got to decide whether they're normal or abnormal. Some criteria to decide whether they're pathological or abnormal Q waves. Is it bigger than one small square? Is it greater than 2 millimeters deep? Essentially, Q waves are abnormal if they're big. That's the take-home message here. If you see an abnormal Q wave, it's probably due to a previous myocardial infarction. That's a permanent change, so you can't tell the age of the infarction based on a Q wave. It will come on within the first few hours of a STEMI or a myocardial infarction, and it'll stay there permanently. So what do you think of the Q waves on this ECG? Well, we can see a Q wave here and here. They're not very big. Some small ones over here as well. I'd like to point out this here and remind you that this is not a Q wave, alright? There is a small upwards deflection at the start of each of these QRS complexes, so this is a S wave. Admittedly, that looks more like a Q wave, but again, it's small, so I'd be quite comfortable saying that there are no abnormal Q waves on this ECG. What about this ECG? Well, that's a Q wave, and that's wide and certainly more than 2 millimeters deep. That's a big Q wave. That's a big Q wave. And all through these precordial, all through these chest leads, we've got big Q waves. So there are a lot of abnormal Q waves in this ECG, all through the inferior leads, 2-3 AVF, and all of the chest leads. This is bad news for your patient. Now, R-wave progression was the other thing we mentioned that we'd look for on the QRS complex. Now, remembering that the ventricles depolarize downwards and towards the left, okay, if you think about your axis, that bottom left quadrant, so the ventricles depolarize towards the left, that means that the right-sided leads, okay, like V1, should be negative, okay, because we're depolarizing away from those leads. At the same time, we're depolarizing towards the left-sided leads, so V6 should be positive. Now, when we say R-wave progression, all we really mean is that there's a gradual transition, a nice smooth transition between the negative V1 and the positive V6, and you can see that really nicely in this example here. So it's predominantly negative with a small R-wave just there. That R-wave gets bigger, and then bigger again in V3, bigger again, and we've lost a bit of S-wave until we're entirely positive by the time we get around here. So this is an example of good R-wave progression. Now, when the R-wave is equal to or greater than the S-wave, then we label this point as the transition point, and normally it occurs somewhere in the middle, okay? V3 or V4, the middle two chest leads. If there's poor R-wave progression or abnormal R-wave progression, it's usually a sign of an anterior MI, although there are some other causes, as you can see here. Essentially, it's sort of the same sort of pathology as Q waves, but not quite as severe. Okay, so if it extends to be a full thickness infarct, you usually get a Q wave, whereas if it was not quite a full thickness, then you might get poor R-wave progression, but still might not get Q waves in these leads. So that's why you're looking for R-wave progression. Now let's put it all together and assess the QRS complexes on this ECG. So we'll start with width. Are they wide or narrow? And I mean, if we count it out, that looks to be 1, 2, and a little bit less than 3 squares for sure. So narrow QRS, that's good. That means all the conduction is happening down the normal conducting pathways, okay, through the bundle of His, the bundle branches, Purkinje fibers. So we've got normal ventricular conduction. And that means that our ST segments and T waves, whatever we see when we look at those later on, are going to be primary changes, okay? They're not going to be affected by our QRS complex. Alright, so we're happy with width. Next, we're going to look at the height. Alright, now, again, this comes more with practice, but these look like normal-sized QRS complexes. And then we said we'd talk about Q waves. So, no Q waves here. Again, little R wave making this an S wave. So, no Q waves. No Q waves to be seen. So, not really much going on from a Q wave perspective. Maybe a small Q wave there, but again, it's small, so there are no abnormal Q waves in this ECG. And so now we'll move on to R wave progression. Small R wave here, bit taller and bigger than the S wave, so transition point in V3, which is normal. Taller, and now we're predominantly positive. So this is nice. This is good R-wave progression. So overall, we'd say these are narrow QRS complexes of normal height/voltage, good R-wave progression, and no abnormal Q waves. Alright, what about the QRS complexes in this slide? They're not normal, that's for sure. Looking at the width, now they just sneak in within the 3 small square limit, okay? They're just under 120 milliseconds, so the width is okay. The height, again, they look to be about the normal height. They're certainly not unusually big or unusually small. In terms of Q waves, we've got a slightly big Q wave here in lead 2 and in AVF, and certainly a big Q wave here in lead 3. So our inferior leads have some abnormal Q waves. Some normal Q wave in V6, but otherwise that's it. And what about R wave progression? Well, in a QRS complex of this shape, it's not really worth mentioning, okay? So we've got this RSR pattern. We're already quite positive in V1, so in terms of our R wave progression, that's already abnormal. Remember, that shouldn't happen until we're in V3 or V4. So these are abnormally shaped QRS complexes, and although we haven't discussed this yet, this is because this is a right bundle branch block pattern. After the QRS complexes, the next thing to look at are the ST segments. So let's do that. Are the ST segments deviated in this ECG? And of course, I'm going to take you through the physiology first. There's nothing going on electrically during the ST segment, okay? The ventricles have depolarized. They haven't yet repolarized, okay? That's our T wave. So there's not much going on electrically. Now, that's important to understand if, and I encourage you to do this, if you can be bothered reading the mechanism of ST segment elevation. The first thing you have to understand is nothing is going on electrically in the ST segment in the normal heart, okay? And when you have ischemia, it sets up things called a current of injury, and that causes your ST segments to change, but we won't go into the mechanism today. What you should look for on the ECG is ST segment elevation, ST segment depression, and the shape of that elevation or depression, okay? So if it's concave up, is it concave down, is it horizontal? Those things, they mean different things. Now, normally the ST segment will be concave up. That's the normal shape, and even if there's a little bit of ST segment elevation, if it's concave up, that may mean it's all right. On the other hand, if it's concave down or horizontal, that's more likely to be ischemia. Having said that, any ST segment elevation can be ischemia, so it always has to be in the back of your mind. Alright, so on that topic, what causes ST elevation or depression? Well, ischemia is always the first thing that comes to mind. What I want you to realize is there are a lot of different causes, okay? So any of these things, and there are many more. Alright, so when you see ST segment changes, don't just think ischemia. It should be the first thing you need to rule out, but it shouldn't be your only differential. So are there any ST segment changes in this ECG? Well, I hope it's pretty obvious to you, but particularly looking in the chest leads, we've got quite significant ST elevation in the anterior leads, probably most notable here in V4. Okay, as well as that, we also have reciprocal depression, the little bit of ST depression, again, comparing to this TP segment, ST segment depression in lead 2, lead 3, and AVF. So, in this case, this is a STEMI, alright, quite an extensive one. Alright, what about this ECG? Well, again, we've got a little bit of ST segment elevation in V1, V2, V3. It's not as marked as the previous ECG, and in this case it turns out this was due to the left bundle branch block, okay? We have a wide QRS complex. Remember, in that case, the wide QRS is likely to be affecting the ST segments and the T waves, and so in this case this wasn't due to ischemia. Alright, after the ST segment comes the T wave. So are the T waves abnormal? Once again, we're going to briefly talk about the physiology. So T waves, as you know, these are the repolarization of the ventricles. Now, I should mention, anything that disrupts depolarization usually disrupts repolarization. So what I'm saying is, if you have an unusual QRS, okay, this is what we were saying before, if you have a wide QRS, well, that means your depolarization was disrupted in some way, okay? And now that means you're probably going to have the ventricles repolarizing in some abnormal fashion, and so there'll probably be a T-wave change, purely because the QRS complex was abnormal. Alright, so keep in mind when you're looking at T-waves, if they look abnormal, but there are also abnormal QRS complexes on that ECG, that may be the reason for the T-wave changes. Alright, but of course things you have to consider, ischemia. Alright, that's always going to be the first thing that comes to mind. But there are other things that can cause it as well, so bundle branch blocks, hypertrophy, any prolonged QRS complex can cause an abnormal T-wave. So when you're looking at the ECG, what I need you to check, the orientation. Are the T waves upright or are they inverted? Okay. Now it's normal for them to be inverted in some leads. Okay. It's usually inverted in V1 and AVR, and occasionally it's inverted in V2 and some of the inferior leads. Although this is a bit harder, it's a bit non-specific. It's hard to say. Is that abnormal for that patient or is it normal for that patient? If it's the first ECG and they've come in with chest pain and inverted T-wave in V2, you probably have to keep an eye on them. You can't just send them home saying they had a normal ECG. Alright, so that's orientation. Should also mention the height. Now, T-waves can be quite tall. in hyperkalemia, for example. Now that's quite important because if potassium gets too high, someone goes into cardiac arrest. That's certainly not something you want to miss. They can also be quite tall. They call them hyperacute T waves as one of the earliest signs of myocardial infarction. So check the orientation, check the height. So going back to our original ECG, are the T waves abnormal? Yes, they certainly are. We've got an inverted T wave in lead 1, lead 2, lead 3, AVL, AVF, and we've got what we call biphasic T waves in some of the chest leads, okay? They go up and then down, so we call them biphasic. Alright, we've got that in V2, V3, and then inverted T waves in V4, 5, and 6. I'll also point out that the leads that usually have inverted T waves, V1 and AVR, actually have upright T waves, so that's actually pretty unusual for those leads. So we have widespread T wave changes in this ECG. So after the T wave, there's just one last thing to check, and that's the QT interval. Alright, now before we touch on that, I'm just going to briefly go through some definitions. The QT interval is defined as the time between the start of the QRS complex and the end of the T wave. Okay, it doesn't matter if there's no Q wave. In that case, it'll just start from the R wave. Point is, start of the QRS complex till the end of the T wave. Physiologically, we've got ventricular contraction, as well as depolarization and repolarization, all occurring within this QT interval. Now, the QT interval will vary with the heart rate, okay? At faster heart rates, the QT interval will be short. At slower heart rates, the QT interval will be longer. So you end up with the formula that calculates the QTC, or the corrected QT interval, corrected for the heart rate. So that formula is the QT interval that you measure divided by the square root of the RR interval in seconds. Now, I certainly can't be doing these square roots in my head, certainly not in the middle of the night on ward call. So as a rule of thumb, the QT interval should be less than half of the preceding RR interval. And I'll show you what I mean by that on the next slide. But just before we get there, we've got some normal ranges. Notice that they're different in men and women. So the QTC is considered prolonged if it's greater than 440 milliseconds in men and 460 milliseconds in women. And basically, once you get above 500 milliseconds, well, now there's a risk of torsades VT, okay, ventricular tachycardia, and essentially cardiac arrest. And that's what we're concerned about when we see a prolonged QT interval. Alright, so what is the QT interval in this ECG, and is it abnormal? Well, I've blown it up for you. So again, to get us out of doing some square roots, we're going to compare the QT interval with the RR interval. Alright, so there they are highlighted here. And if the QT interval, as it is in this case, is longer than half the RR interval, then that's probably abnormal. Okay, and in this case it is abnormal. To be a bit more thorough, I've gone through and actually calculated it for you. So I've measured 640 milliseconds for the QT interval. The RR interval was 1.08 seconds, so plugging it into the formula, you get a QT interval of 615, so this is a prolonged QT interval. Alright, you made it, that's it. So that's my system for interpreting the ECG. 3 initial features: rate, rhythm, axis, then look at the waves and intervals. And if you can't remember the list, just read them off the ECG. P wave, PR interval, QRS complex, ST segment, T wave, and don't forget the QT interval at the end. Doesn't matter whether you use that system or some other system that you prefer, as long as you have a system and you use it when you interpret the ECG, it really is a get out of jail free card. Even if you have no idea what's going on, if you can describe everything on the ECG to your consultant, then they can help you out. Now, this slide's really just for your reference. I've tried to cram everything I've discussed onto one slide more for revision purposes than anything else. Alright, I hope it helps. So, one last look at this ECG we've been working through the whole time. So, going through it systematically, rate 54, it's regular, it's sinus rhythm, the axis is normal at about 45 degrees. The P waves look normal, the PR interval is normal at 180 milliseconds. The QRS complex, it's borderline, but I must have decided it was a little bit prolonged, but in reality it's right on the border. The QRS complexes are abnormal in shape. There's an abnormal Q wave in lead 3. There's a RSR patterns, so this is the right bundle branch block pattern. We can't really assess R wave progression on this ECG. There's some ST segment changes with some slight ST elevation in V1 to 3. There's T wave changes with inversion in leads 1, 2, and 3, AVL, AVF. There's biphasic T waves in V2 and V3, and more inverted T waves in V4, 5, and 6. The QT interval, it's prolonged with a QTC of 538 milliseconds. And so if you're going to interpret this, I would say this is an abnormal ECG. It's a sinus rhythm with a right bundle branch block with widespread inverted T waves, ST segment changes, and QT prolongation. However, this is pretty non-specific, and there are multiple differentials for this ECG, including ischemia. So the remainder of this lecture is just a quiz, a chance for you to test yourself and put this stuff into practice. So let's jump right in. Alright, so interpret this ECG. I'll get you to pause it here, and then I'll get straight into the interpretation. So the rate is 66, it's regular, we're in sinus rhythm, and the axis is normal at about 30 degrees, just based on these relative heights of lead 1 and AVF. Lead 1's much taller, so I'd say close to 30 degrees. Looking at the P waves, they're normal. The PR interval is also normal. The QRS complexes are narrow. They're a normal height. There are no abnormal Q waves. There's good R wave progression with a transition point in V3. Normal shape to the QRS complexes. The ST segments are normal. There is an inverted T wave in lead 3, but otherwise they're pretty normal. And the QT interval is grossly normal if you compare the QT interval, assuming it should be half the previous RR interval. But I've gone ahead and calculated it for you just to be sure, and it is normal, 379 milliseconds. Interpretation. This is a regular sinus rhythm with a singular inverted T wave in lead 3. This is essentially a normal ECG. Alright, so here's another example. Again, I'll get you to pause it, and then I'll start talking through it. So, it's regular, rate of about 78, sinus rhythm based on upright P waves in lead 2 and inverted P waves in AVR. The axis is normal at about 50 degrees. Now AVF is slightly bigger than lead 1, so I'd say we're beyond 45 degrees, closer to 50 degrees in this case. The P waves are normal. The PR interval is normal at 120 milliseconds. The QRS interval, it's slightly widened. Okay, it's right on the borderline, right at 120 milliseconds, so it's borderline. Looking further at the QRS complex, we've got deep Q waves in lead 3 and slightly bigger than usual Q waves in leads 2 and AVF as well. So our inferior leads have abnormal Q waves. We've also got the RSR pattern in V1, V2, V3. So that's an abnormal shape, and with this abnormal shape it's a bit difficult to assess the R wave progression. Looking at the ST segments, we've got ST segment elevation in leads 2 and V3 through to V6. There are abnormal T waves with T wave inversion in lead 1, lead 2, AVR, and V4, 5, and 6. And the QT interval, it looks grossly normal, and when we do the maths, the QTC comes out at 424, so that's fine. So my interpretation of this one is that this is a sinus rhythm with a right bundle branch block, and there are ST segment and T wave changes. Again, there are multiple differentials. Things to include would obviously be ischemia, pulmonary embolism, but it would depend on the history as well. Alright, here's another example. Get you to pause it, and then I'll describe it. So the rate is 48, and it's mostly regular. We'll get to that in a second. So we have a sinus rhythm, a sinus bradycardia based on that rate. The axis is normal, about 70 or 80 degrees. Okay, so lead 1 is positive, but it's very small compared to AVF. So the axis is pointing pretty close to AVF, 70 or 80 degrees. Now the P waves, they mostly look normal, except for this one here, which looks different to all the others, and that's the one time where it's irregular as well. Okay, so this is a premature atrial contraction, or PAC. Alright, an ectopic beat. Alright, now we'll talk more about those in a different lecture, but there's an example of an atrial ectopic beat. Otherwise, the PR interval is prolonged, so it's longer than one big square. You can see that quite clearly here. Alright, the P wave starts basically on that heavy line there, and the QRS complex takes more than one big square to begin. Okay, so a prolonged PR interval. The QRS complex themselves, they're narrow, 80 milliseconds, so that's normal. The QRS complex otherwise, there's an abnormal Q wave in V3, alright, so there's no Q waves in V1 or 2, alright, we still have these little R waves, but there's no R wave in V3, so this is just a Q wave, and you shouldn't have any Q waves in V1 to 3, so that's quite abnormal. As well as that, looking at the R wave progression, we have a small R wave here, but it really didn't get any bigger in V2, and it certainly didn't get any bigger in V3. In fact, there's no R wave at all. And then you get to V4, and all of a sudden it's positive. So this is not good R wave progression, this is poor R wave progression. And that's quite abnormal. Otherwise, they are of normal height though, right? No hypertrophy. Right. ST segments, there is some mild ST segment elevation in V3. The T waves are normal, the QT interval is grossly normal, and the QTC is 431, so normal. Alright, so interpretation. This is a sinus bradycardia with a first degree heart block and poor R wave progression, which essentially indicates a prior anterior myocardial infarction. There's a singular premature atrial contraction, which isn't particularly significant on its own, just something to point out. So this is an interesting ECG in that at first glance it doesn't look particularly abnormal, but if you look closely you do start to notice things like the first degree heart block, poor R wave progression, and you can actually see there is conduction disease and evidence of ischemic heart disease on this ECG. Alright, here's another one, so I'll get you to pause it and then I'll describe it. Alright, so the rate is 78, it's irregular, 45 to 100 is the range of heart rates that we're seeing here. It's not sinus rhythm, there are no P waves, so definitely can't be sinus rhythm. There's a normal axis at about 45 degrees. No P waves, so I can't measure a PR interval. The QRS complex is narrow. There are some Q waves, but they're all small, normal-looking Q waves. There's good R wave progression with a transition point in V3. The QRS complexes are normal in morphology. The ST segment's normal. The T wave's normal. The QT interval is grossly normal, and I've measured it at 380 milliseconds. So, interpretation, this is atrial fibrillation with a normal ventricular rate. Alright, here's another one. I'll get you to pause it about here, and I'll start to describe it. Alright, so we have a bradycardia, a ventricular rate of 36. And I say ventricular rate because looking at the QRS complexes, we've got 6 of them in the rhythm strip, so 36. But we can clearly see that there are more P waves than there are QRS complexes. So the atrial rate is different. It's about 120. Now, The rhythm is the most important thing here, and we've already alluded to it. There are more P waves than there are QRS complexes, so there is a heart block here. Now, I haven't really discussed heart blocks with you just yet, but this is a complete heart block. The P waves are perfectly regular. There's a P wave, P wave, P wave, and so on. One will be buried in this T wave here. P wave, buried, P wave, that's a P wave, etc. The point is those P waves are regular. The QRS complexes are also regular, but they're totally unrelated to the P waves. So this is a ventricular escape rhythm in the setting of a complete heart block. Alright, really, it's just a complete heart block. And whenever you have a complete heart block, the fact that the ventricles are still beating means there's a ventricular escape. But we'll talk more about that in another lecture. Just to be systematic, the axis, well, there's a left axis deviation. 1 is positive, AVF is negative, and lead 2 is negative, so it's definitely a left axis. P wave, normal shape, no relation to QRS complexes. They are upright in lead 2, and they are inverted in AVR, so they are sinus P waves, but the fact that they're not conducting to the ventricles means the heart is not in sinus rhythm. The atria is in sinus rhythm, but the ventricles are in a ventricular rhythm, okay? A ventricular escape rhythm. The PR interval really isn't applicable when there's no relation here. As you can see, every PR interval is totally different. This one's slightly it's prolonged, that one's normal, that one's short, but in reality these PR intervals are meaningless. The P waves are not conducting into QRS complexes. This is all just, well, it's irrelevant really, not applicable. The QRS interval, well, they're wide, okay, and that makes sense because they're ventricular in origin, okay, they're not coming down the usual conduction pathways, it's a complete heart block. Alright, so this is a ventricular origin for each of these beats, so we've got a wide QRS complex. We won't bother to describe the shape very much now, seeing as the ventricular beats, they're not going to have the usual shape. There is some ST segment depression in V3 of about 1 millimeter. There's inverted T waves in AVL, AVR, V1 and 2. The QT interval is grossly normal, given the heart rate. So it's 560 milliseconds, but once you correct it for the heart rate, 442. So that's probably okay. Alright, so interpretation, it's a wide complex bradycardia with an atrioventricular dissociation. That's the key phrase, alright? That's what the diagnosis of complete heart block hinges on. The atria are doing one thing, the ventricles are doing another, and there's no communication between the two. This is a complete heart block. Okay, this is our last example. Once again, I'll get you to pause it here, and then I'll get on with describing it. Alright, so it's a tachycardia. It's a wide, complex tachycardia. The rate is about 162, although it ranges from 100 to 300. It's irregular, and it's clearly not sinus rhythm. Okay, there are no P waves. We can't see a P wave. You know, upright in lead 2, inverted in AVR. No, not sinus rhythm. All right. Now it's a wide, complex tachycardia, and whenever you see one of these in a patient who's deteriorating, you just have to assume it's ventricular tachycardia. But I will go through the rest of the steps just for formality's sake, and there is some use to these things. So, axis. What's the axis? Draw a grid, start with lead 1, and I'd say lead 1's negative. Now, that's because I'm saying that this here is QRS complex, and I'm going to say that this here is T wave. It's not always very easy to tell. For example, when we get down to here, you know, I still think this part, you know, this is QRS complex, and this is T wave. Not always easy to tell, sort of comes with experience, but I guess also there does have to be a T wave somewhere, you know, so I'd say this is T wave, and so then you can work backwards, you know, this must be QRS complex, this must be T wave, this must be T wave, this QRS complex, you know, but I can see that it all looks pretty close to the same. But anyway, going with that, if that is T wave and that is QRS complex, then that's certainly negative. So axis-wise, we must be over on this side. Alright, next we're going to look at AVF, and we find it's also negative. Again, QRS complex here, T wave there, that means that this is negative. Alright, so we're up here. Going to our diagram, that's our extreme axis or our northwest axis. So we've got a northwest axis and extreme axis deviation, and that's worth knowing. Okay, so the reason that's worth knowing is because although in this case it's pretty clear that this is a ventricular tachycardia, it's not always clear. Sometimes, especially when it's irregular like this, you might be wondering, is this atrial fibrillation with a bundle branch block? Okay, because that will be tachycardic, and the bundle branch block will give you a wide QRS complex. So you can have a wide complex tachycardia that's not ventricular tachycardia. Alright, so you might be trying to figure it out, and one of the things that can help distinguish is the axis. If you've got an extreme axis, that means, well, that's more likely to be a ventricular tachycardia. Alright. There are no P waves, and again, that's useful because if you do have ventricular tachycardia, you do sometimes see P waves, and what you should see in a true ventricular tachycardia is that they have no relation to the QRS complexes. The atria are firing, but it's got no relation to what the ventricles are doing. Alright, you've got complete AV dissociation in ventricular tachycardia. Although, in a case like this, you may not have any P waves anyway, okay? And that can happen in VT. QRS complexes, well, they're wide, they're high voltage. You can't interpret ST segments and T waves in this context. Interpretation-wise, it's a wide complex tachycardia, it's irregular, the rate is up to 300 beats per minute, it's ventricular tachycardia. Now, briefly I'll just mention that if you're faced with a deteriorating patient, someone who's arrested or is becoming quite hypertensive and compromised, if they've got a wide complex tachycardia, that's not the time to be trying to figure out is this SVT versus ventricular tachycardia. If you have a deteriorating patient and a wide complex tachycardia, you just treat that as ventricular tachycardia. You can't get into any trouble if you do it like that. You can get into trouble if you try using treatments for SVT in the wrong patient. Okay, so it's much safer just to use the treatment for ventricular tachycardia. And if that's a deteriorating patient with hemodynamic compromise, the usual treatment is direct current cardioversion, or shocking them. Alright, well, I hope that all made sense. I hope that was helpful. The next lecture is on ischemic heart disease. I hope to see you there.